everybody. We're really excited to be talking to you today about our study, which is exploring opportunities to extend telehealth treatment and mental health support for people who use opioids here in North Carolina, with a focus on improving rural access of treatment. So our kind of format today is I'll give some brief intros of our panelists, and then they'll each give about a 5-minute introduction of their work in this area. And then we'll have some prompts and follow up and also open it up to the floor to ask any questions that you all about this work or about our work in this area more generally. So first, my name is Brandon Knettel. I'm a licensed psychologist, assistant research professor at the Duke School of Nursing with a secondary appointment here at the Global Health Institute. My areas of specialization are global mental health and health behavior, with a focus on care engagement, stigma reduction, and mental health support for people living with HIV and other health conditions. I'm new to opioid research, and a lot of my prior work has been conducted internationally, so I'm really thankful to this team for kind of bringing me into the fold and helping me to explore this new area of research here in North Carolina. Our first panelist will be Nidhi Sachdeva, MPH. She's a senior research program leader who built and leads a portfolio of prevention research, implementation science, and evaluation projects focused on reducing harms and saving lives from the opioid epidemic. Nidhi came to Duke from the North Carolina Department of Health and Human Services, Division of Public Health, Injury and Violence Prevention branch, where she led strategic planning, partnership development, policy and program implementation, and local capacity building for statewide injury and violence prevention efforts, with a special focus on the prevention of drug poisoning and overdose death. Our second panelist is Padma Gular, MD, who's a board-certified physician in anesthesiology and pain medicine. She specializes in advanced interventional pain management and is recognized for her care of patients with acute and chronic pain. As professor of anesthesiology and population health, Dr. Gular is dedicated to training the next generation of physician leaders in pain medicine. She both teaches and advises medical students and trainees on the resident and fellowship level. And she's director of pain management strategy and opioid surveillance for Duke Health, and has an impressive research portfolio as head of the PROMISE Lab, which stands for Pain Relief and Opioid Mitigation Innovation Science. Third, Hillary Campbell is director of the North Carolina Health Professions Data System. She recently, I think as of this week, left us here at Duke for UNC. Until this month, she was a research associate at the Duke Margolis Center for Health Policy, and she also recently served as the acting special assistant for the chief data officer of the NC Department of Health and Human Services. As both a doctor of pharmacy and a lawyer, Hillary provides a unique perspective on a wide variety of clinical, legal, regulatory, policy, and technology issues. So we're thrilled to have Hillary on this project. And finally, last but not least, Dr. Teresa Coles, PhD, is an assistant professor in the Department of Population Health Sciences here at Duke. She specializes in the development and psychometric evaluation of clinical outcomes assessments, and her research interests include evaluating clinical outcomes measures in clinical practice. She's the lead investigator of Harm Not, an evaluation of the medication for opioid use disorder program at Granville Vance Public Health, a group who's also a partner in the current research. So that's our wonderful panel, and I'll hand it over to Nidhi to give a brief outline of her work.
Good afternoon, everybody. It is so great to be with you all. I'm again delighted to be among this panel to talk to you a little bit about the work that we're doing. I thought we might ground the conversation and just orient folks to sort of what the opioid or overdose epidemic looks like in North Carolina real quick, just to kind of give us a sense of who we're really trying to help and what we're doing at the end of the day. So I come from a background of local public health. That's sort of where my heart is. I left my heart in the community a long time ago, so I've been chasing after it ever since. And so I'm really just excited to be able to offer some perspective on how to engage with community folks and do meaningful work with centered lived experience and solve problems together, because we certainly know that it's really complicated. But in North Carolina in 2019, an average of 6 people died every single day from unintentional medication and drug overdose. When I started doing this work 10, 15 years ago, the number was much smaller, unfortunately. And so we are, although we've done a lot of really great things, focus on systems, focus on policy, focus on community efforts. Unfortunately, we're dealing with a sort of a combination or crashing of multiple epidemics at the same time. And so we're losing more and more folks every day. And COVID hasn't made it any easier for us. But with the unprecedented availability of cheap heroin and fentanyl, more people are dying. So this is unique in that this is not the first overdose epidemic we've ever had, especially specifically for opioids, but it's the first time that we've really had to deal with some of these, fentanyl, carfentanil, and these analogs that are much more powerful than they ever have been. And of course, we're dealing with the consequences of unregulated drug supply and failed drug policy. And so unfortunately, more and more people are dying, and they're dying much more quickly, which offers unique challenges as we try to patch up our systems of care in order to support people who are struggling the most. So North Carolina is a unique state. We're sort of geographically situated. We've got on the coast and the mountains, we've got multiple interstate highways coming through. So the geographic spread of North Carolina is very interesting. And so the darker blue counties, of 100 of them, are the ones that have been hit the hardest with the overdose epidemic in North Carolina. So this is something we also want to make sure that we keep an eye on. And so the Tempo project that we're going to be talking about today is taking lessons from one part of North Carolina and trying to sort of expand and scale up to other parts of the state. We have a lot of innovation happening on the ground, and so I think this is a really unique opportunity for us to have an academic and community partnership to take lessons learned from one place and try to apply it to another. But in North Carolina, this is sort of I'm going very quickly through data slides, but this is sort of the historical perspective of where we are. Unfortunately, we are still, the numbers are shooting up. So 78% of unintentional opioid overdose deaths in 2019 were due to illicit opioids. So the green block is representing sort of prescription opioids, and given the health systems taking responsibility and doing all that they can, providers understanding that they have a role to play and have been doing really good work in trying to more safely prescribe opioids and support our patients, those numbers have gone down, which is great. But unfortunately, we have a whole generation of folks that are physically dependent on opioids. And again, our systems of care that aren't necessarily caught up with the way that the epidemic is changing so quickly. And so the darker blue represents the heroin and synthetic narcotics, which is unintended shooting up numbers. And so we have a really unique opportunity at Duke. The Duke Endowment very generously gave a signature grant to the School of Medicine, and we've been able to build the Opioid Collaboratory over the last few years. And the Collaboratory is an open space, a creative process. That's where a group of people can work together to generate solutions to really complex problems like the overdose epidemic. And so our mission, like Brandon alluded to, is to save lives and reduce the harmful impact of opioids. Our focus is very much on the development, implementation, or evaluation of sustainable system-level interventions. And we very much center the principles of harm reduction in all that we do. So any positive change is sort of our goal here. We understand that harm reduction is both a combination of sort of practical strategies on how to reduce harm, but then it's also a social movement and social justice centered work. And so we're looking at the whole spectrum here, everything from before patients even get access to opioids or exposure to them, all the way to meeting people where they are in their use disorders. So we very much focus on the people that are most vulnerable and try to center that in all that we do. Our overall program strategy for the Opioid Collaboratory is basically threefold. We're really trying to increase data surveillance, increase health system quality, and increase public health, and we do this in a variety of different ways. We've got 25 projects in our collaboratory, including Harm Not, as well as Brandon's project with Tempo. And so I wanted to just give sort of credit to some of the inspiration of Tempo and some of the, again, lessons we were learning from other places to bring to this project. And so Harm Not, which Teresa will be speaking to in a bit, we're also doing a really unique project. We're providing medication for opioid use disorder to participants at syringe service programs using telemedicine in 2 counties in North Carolina, as well as working with local health departments all across the state to evaluate their prevention strategies around overdose. And so we're taking those lessons learned, those relationships, those partnerships we've built over a long time, and then bringing them to the Tempo project. But very much a systems approach. So this picture is more about just the complexity and the intersections of the work that we do. And so there's a lot of overlap between the sort of focus areas and knowing that no one person experiences this epidemic or this, opioid use in any one vacuum. And so we have to very much acknowledge the context that they're in. And so our projects also reflect that as well, and intersectionality. The Duke Opioid Collaboratory is definitely a school-wide effort. So we are housed within the Population and Health Sciences Department, but we work with many others across the school, as well as other groups across Duke. And Duke Health, of course, is a really big partner. This is just a little preview. We have a lot of external partners. Our projects span multiple settings. We work in communities, we work in jail systems, we work in local health departments, statewide, we work in churches, we work in hospital and healthcare systems, community-based clinics. And so it's just a really unique opportunity for us to do all that we can to try to mitigate the overdose epidemic. But I'm excited to get into the rest of the presentation and hear from my other panelists. So Padma, I think I'm going to hand off to you.
Thanks so much, Nivi. That was excellent. And just so proud to see all the amazing work that the group is doing. Thank you all for your time. I'll focus a little bit on prevention science and early treatment access and the role of the health system and how it is partnering with, collaboratories and other community efforts to ensure that we're taking care of our community with both safe opioid prescribing and early treatment access. So with that, I want to start with, just a focus on what the Department of Health and Human Services prevent, reduce harm, connect to care approach, and just mirror that with how we have similarly in our region and community approach this, on how best to address the issues that we're facing. We have the health system is actually dedicated resources for pain management strategy and opioid surveillance. And I do lead that particular effort for the health system. And what does that actually consist of? So what's our approach been? We have 4 large committees with stakeholders across the board in terms of both providers, but also patient representation, because we do want to see and community representatives to ensure that we have all the voices at the table. And the 4 major groups are the optimal management of pain, which focuses on, it's great to say that, there are issues with opioids and we need to do something about it because that's extremely important. But at the same time, for most people, they're taking opioids because they suffer from chronic pain. And are we making sure that we are managing that condition, and do we have good alternatives and strategies to ensure that we're not forgetting our focus on ensuring that the debility that chronic pain brings is being addressed as well. We have the Safe Opioid Prescribing Group, which is focused on the best practices as far as taking, if we are prescribing opioids for patients, how we do it, and what we should be doing to continue to monitor and support. And for early detection, very honestly, to ensure that patients don't develop opioid use disorders and then subsequently end up relying on other substances, et cetera. And then we have a group which recognizes that opioid use disorder is real. And as Nidhi pointed out, there are many patients, unfortunately, in a population that is already afflicted. And so the management of opioid use disorder, how do we improve that, and how do we provide access to it, is the key focus of that particular group. The diversion and risk mitigation group is focused on ensuring that unintentional, flooding the community with excess opioids or substances, how do we reduce that harm that could potentially be caused, but also to understand and recognize that providers themselves may also be affected, and what can we do to care for them, care for the at-risk provider, and ensure that we're supporting them as well. So those are the focus areas. And we have a very committed and collaborative infrastructure with partners in the community, region, and state. The reason for that is that the patient population that Duke Health serves, as happens often with quaternary centers such as Duke, do not come just from our primary communities, though that is our area of focus, but we actually have patients from all over the state and from the neighboring states, and some of them from different parts of the country. And so building this collaborative infrastructure is really, really important. And we put a lot of emphasis on developing those relationships so that our patients can receive comprehensive and standardized care across any platform, irrespective of where they're coming to us from. One of the key things, Brandon's project is close to our heart, is because the COVID pandemic, while it has definitely upturned everything that we know and do in some way or the other. It has also allowed for some progress in streams that I think are going to be extremely helpful, and that is the use of telehealth to improve both access, because expand access, especially into rural communities, to be able to give the same expertise in those areas. And it also has shown that you can improve compliance by enhancing the patient experience journey, by making it easier for patients to connect and stay connected with us. And so this is Duke Health's approach, where every member. So in this particular slide, what you're seeing is our team members, the front desk staff, on what is being done to ensure that the patient experience journey is the best we can make it, with connect, care, and close. Just making sure that we are closed loop with the patient to understand what their needs are and respond to their needs, meet them where they are, essentially. And so we are extremely excited with the expanded telehealth services we are able to provide. And what I'd like to share with you in the next few slides is that, as Nidhi indicated, there has been progress, and we're delighted to see that and share what we have been able to contribute to in the care of our community with that. For instance, so the opioid overdose deaths dropped in 2019 for the first time in 5 years, as did emergency department visits across the state overall. And so what has that been like with Duke University Health Systems? And if I could just share that with you guys. So as far as the safe opioid prescribing trends, just to show you what we monitor on a regular basis, you can see here that, and these are live dashboards that we get. We literally can monitor on a day-to-day basis, and we do. And we also can drill down to see who are the patients coming in, what are their needs. And you can see over here that over time, the patients coming in being admitted on high dose opioids has gone down, which we see as an indicator of our community, because it shows us that that there are less patients who are requiring high dose opioids at this time in our community as a whole, which is an encouraging sign. We also monitor what we're discharging them on, and as you can see, where 26% of patients back in 2014 used to be discharged on a reasonable dose of opioids, that is down to 15.6%. And while this is really, really important, what's even more important is to ensure that, again, as I said, we never lose sight of the fact that are we ensuring that these patients, the pain is treated, and the quality of life outcomes that are important are still staying high. And we're fortunate enough to see that we are able to do that, even though the percentage of patients has gone down, and also the max doses that we were prescribing has gone down, because we've been able to use, through all our initiatives, other agents for pain management, including non-pharmacological strategies, which can help this population immensely. We also monitor in the ambulatory, outpatient population, where our opioid prescribing rate is, and if there was, as a percentage of ambulatory visits in which an opioid needed to be prescribed. And you can see that over the years, there has been a distinct decrease in that amount as well, with the access and education around alternative strategies, so that opioids don't become the go-to for the management of pain. Here in the what you're seeing over here is just a representation, because we also look at it in terms of the amount that's being prescribed. So greater than 50 morphine equivalents in many stratas is something we consider high dose, and greater than 90 is really, really high dose. So we monitor to see how that, which is what is the percentage of population that requires it, and you can see how it has been going down over time, with all the initiatives and efforts that have been put into it. However, if we keep our focus just on safe opioid prescribing and just reducing the amount of opioids that are prescribed, it can become rather unidimensional. And as it happens with those things, you can have unintended consequences. So merely reducing opioid prescribing, there has been concern nationally that has resulted in increasing illicit and psychoactive drug overdoses, and the need for patients that are just turning to other substances. We at Duke Health were fortunate with, that we have been able to invest to ensure that, as I said, we look for alternatives so that patients' pain is being addressed and they do not need to turn to other things, and also to offer medication-assisted treatment programs so that our patients, again, have avenues of treatment per se. So these are our trends in that regard. As you can see, both for opioid use disorder and the overdose trend overall, In the inpatient and outpatient setting, we see a decrease in all three, which is a good sign, in spite of the fact that in the emergency room, we actually see a slight trend upwards, which shows that even now in our community, we are seeing some patients come in. But the fact that the inpatient numbers have not gone up also helps, because that shows that while these are occurring, these are mostly things that we are able to manage and manage reasonably better than we were before, where they, in terms of being able to help these patients overall. We also monitor very carefully what the medication-assisted treatment trends are, and whether we have any access issues there. Are we able to give them, and you can see here with the upward trend, especially in the outpatient mode, which is really where we most want to make sure that the medication-assisted treatment is offered. The trend has been much higher, because we've invested the resources and expanded access to ensure that patients have that approach. That said, the work that's left to be done is immense, and it's always so exciting to see the level of engagement and interest programs such as this bring, by bringing interested folks together, so we can think together and try to continue to build on the gains we've seen over the last few years with this investment. So with that, I'll end and pass it on to the next speaker.
All right, and I think I'm next. Great. So I don't have slides, but I'm here to talk about our work so far in the opioid space from the policy perspective. And so I'll give a little background about how that has come to pass. And so I work closely with a faculty member named Aaron McKeithen, who both of us, we kind of went on loan to the state for about a year, and he was the chief data officer for the North Carolina Department of Health and Human Services, and I was his staff. And obviously, I think has been already outlined, one of the most critical issues for the state and for the country is the opioid crisis. And so getting a handle on the data around opioid prescribing within Medicaid was one of the things that we kind of took on. We also had the experience in general, while we were at the state, of getting pitched a lot of kind of supposed super sophisticated machine learning, cloud-based, awesome artificial intelligence systems to solve all the state's problems. But we've kind of stolen this notion from Todd Park, a former chief technology officer for the United States, that really in healthcare, we're not at the point where we often need machine learning. We're at the point where we need histograms to understand what the problems are, and just getting those histograms to the right people just counts, really, is what's missing a lot of times. So that's really where we try to focus. It was really simple methods. The first thing we produced was, we call this a placemat, just a really big sheet of paper that outlines some basic opioid related prescribing metrics in Medicaid by county, how many, like the percentage of people that had opioids and benzodiazepines, people on high dose, high duration prescriptions, the average morphine milligram equivalents of the prescriptions in that county, just so people working on in those various counties could understand what's going on, and the communications officers could understand, get a better sense of the opioid landscape in Medicaid. And of course, we also did a lot of contextualizing, so explaining what you can't see in the Medicaid claims data, that these are prescriptions being paid by Medicaid, and you're not seeing prescriptions that may not be paid by Medicaid that people are also receiving, and that it's also, you're not seeing the people who don't have Medicaid, aren't qualified for Medicaid. So it's just one piece of the puzzle. And so doing a lot of contextualizing and explaining in the public policy space was really important too. And so we started there with some basic metrics on opioid prescribing in Medicaid, with some support from the Pharmacy Quality Alliance, who has measures around that they've worked on for a long time on combination and high dose. What do those measures mean? So we leaned on them for our measure definitions that we used. And then from there, when we came back to Duke, we got some funding from Arnold Ventures to do a deeper dive on those types of metrics, looking at people that might be at risk for opioid related harms based on combinations of medications, a history of emergency room visits, for overdoses, things like that. And we did a kind of a retrospective of 2-year cohorts of various groups in Medicaid. And I'll put a link up to that white paper that we published on that. But really the trend that we were seeing was that the supply side was going down. So prescriptions, opioid prescriptions were going down, but we're seeing at the same time, obviously the crisis getting worse. And so we could kind of say, it looks like it's not really where you want to put your effort on just reducing the number of opioids, prescription opioids getting to people without focusing equally or more so on the treatment side, or you may end up with just more harms. So we also looked at the supply of medications for opioid use disorder, and we're able to sketch that out as far as we could see that in the Medicaid claims data. And it was going up, which was good, but it was not keeping up with the pace of diagnoses of opioid use disorder. So that's clearly a place that we could say, look, here's where we should probably be focusing, is making sure there's adequate treatment. So this is kind of outlining our interest in this project too, and why we're glad it's going on. And then from there, we also looked at new opioid starts in Medicaid, and we saw that dentists were a specialty area that produced a lot of new opioid prescriptions. And so we got interested in digging into the prescription characteristics of dentists prescribed opioids for the Medicaid population. And so that is the project we were working on in the Collaboratory. We got some funding from this group to look at the characteristics of dentists prescribed opioids for Medicaid patients. And this is a theme that we saw throughout all of our work, is that it's very mixed. Rarely do we ever come across a trend where it's like, oh yes, definitely, here's a strong, consistent concern across this whole area. It was the same for looking by county opioid prescriptions. It was not an obvious kind of rural-urban story, which sometimes gets told. It was mixed across rural and urban counties. And it's the same with the dentist prescriptions. It was generally quite low. There's some prescribers, some dentists that prescribe a lot, some that prescribe less, even for the same procedure. But there's characteristics we can't always see. So it's not, so that's more contextualizing we were doing, is saying, well, you can't necessarily just go after all of the dentists that prescribe a lot without understanding more about what's actually going on in that practice. And so that's one gap that we kind of identified, is that some more mixed method research, some more on the ground community-based research could really inform this kind of data-based analysis. And I think that's another real benefit of this study that Brandon is leading, is that we have these kind of anecdotal stories and potential factors that could be affecting why there isn't more medications for opioid use disorder being distributed, why there isn't more naloxone being distributed, why some prescribers prescribe more opioids than others. But because it is so local and so dependent on so many contextual factors, I think understanding that in the particular context you're looking at is particularly important. And the other, I'll mention one other kind of perspective shift that we worked on a lot at the state, was helping people to think about what questions, if we had the answers to them, could we act on, to kind of give people a focus away from what's the latest thing that you happen to have studied or that you were interested in, or the latest kind of run of data that you have, but rather focusing on what questions should I answer, because that answer will allow us to do something or make a decision, especially when decisions are needed so rapidly with various funding streams that come federally, and decisions need to be made quickly about where to put that money, which was another kind of difficulty area we recognized at the state, was that when money comes, you need to be able to find somewhere to spend it quickly in a way that will do the most good for the most number of people. So I realize I'm kind of covering a lot of ground here, but I just want to give a sense of the thinking and the gaps and the perspective, at least at the state policy level here in North Carolina. And I'll turn it over to the next presenter.
That's me. Hi, everyone. My name is Teresa Coles. I'm leading the Harm Not study, which is part of the Collaboratory that Nidhi mentioned earlier. I have bullets prepared. I don't have slides, but I'm hoping that means that you'll still be listening. So our study is really focused on rural North Carolina, and we were interested in working with Granville and Vance counties to look at their rollout of a program for medication-assisted opioid use disorder treatment. We know that rural counties certainly have unique challenges for offering evidence-based treatment for opioid use disorder. Two of those that we know ahead of time are transportation for the patients and also consistent funding from year to year. Transportation was one of the things that Granville and Vance counties knew that they really needed to address. And so they rolled out and established an office-based opioid treatment program where patients would go to primary care clinics within the health department. And as part of that program, they offered, of course, medication for opioid use disorder, both group and individual medical visits, psychosocial support, infectious disease testing, hepatitis C treatment, and immunizations for hepatitis and flu. One key piece about this program is that it's based on the harm reduction model. So folks on the team are working to minimize the harmful effects of drug use in a very non-judgmental approach. This program really started out very small and then expanded. And then the opioid collaboratory group began. And the purpose of our project was really to describe the evolution of this novel program in rural North Carolina. And we were interested in describing the training and operational challenges and facilitators in the program, and identify patient-centered goals and what is definition of success from the patient perspective. We also described and we're interested in describing just the typical outcomes from any type of program, like adherence to a program, results of drug screenings, et cetera, et cetera. But really, the key piece for us was looking at quality of life of patients and the impact of the program on their lives and daily activities. So we undertook a both quantitative and qualitative approach to looking at this program. And I think the piece of our project that really speaks to where Brandon and others are going for this work is what we did with the qualitative work. And I think it sets up the importance of telehealth. So let me just tell you a little bit about it. What we did is we interviewed a number of clinicians and staff members at the Granville Vance clinics, and we also interviewed patients in these semi-structured interviews. And what we found is that the barriers to success at Granville Vance were really inconsistent funding, where there's a lapse of service and access. And one of the things that was really impacted was behavioral health. So having a counselor, having social workers there consistently. That led to a lot of frustration for the patients. And with that drop out of somebody there to help, it was very challenging for everybody involved. The other piece was lack of reliable transportation to the clinic for patients. So the transportation can sometimes influence, of course, missed visits. And guess what? As we started this study, it just so happened that COVID started. So all of a sudden, Granville Vance was forced to go to telehealth, in which they never would have thought about doing otherwise. And so our study not only became a description of how the program was evolving over time, but also how COVID kind of overlaid this evolution. And in the process, what we learned is that telehealth, though it was a challenge in terms of technical issues, what it did is it really kind of bridged the gap for some of the transportation issues for patients. And there still is that need for behavioral health. those are some of our top line findings, and the study is still ongoing. We are almost done with coding our interviews. We're done with the quantitative work, so stay tuned for more, but I'm really excited to be here and thank you for the opportunity.
Great, thanks everybody. As you can probably imagine, with such an impressive and like multivariate group in our research team, that our team meetings are really interesting, and we could just sit for like 2 hours and discuss all of these issues from so many different perspectives. So it's a real strength, I think, of our research team. So I'm going to talk a little bit about the Tempo project, and we had some good teasers there. But while I do that, I want to encourage you to start putting your questions in the chat or Q&A, or once I'm done talking, feel free to just raise your hand, use the raise your hand to speak, to let us know what your questions are. But yeah, the Tempo project, Tempo stands for Telemedicine and Mental Health Support for people who use opioids. We got a nice acronym out of the project, which is always key. This project is really trying to build on what Teresa mentioned, of course the others, which is to take this kind of formative data around the barriers to care and now to start to leverage that towards intervention development. And with my background in mental health, of course, you know, that's kind of where I tend to go, which is to develop more behavioral health services and structured mental health support. There's been some really interesting kind of conflicting data on the extent to which mental health support in collaboration with opioid use disorder helps. And sometimes studies which have like been very structured and focused specifically on use haven't had the outcomes that they had hoped in combination with medication for opioid use disorder. And what seems to help is when you focus on the underlying social challenges in addition to the substance use. And so that's really kind of our focus, is to develop something that's really based on a transdiagnostic treatment model, meaning that we really work at doing a good comprehensive assessment of like what a person's life looks like and what their priorities are for treatment before we jump ahead and start providing structured counseling. And so that's an idea of where we're going to go. And all right, we're planning to first with some formative work in these rural counties. So starting with kind of a more rural focus with both Granville Vance and then another partner in Asheville. And then in Buncombe County Public Health. And then from there, using that to start to look towards developing this intervention model in close collaboration with those community partners. So just a teaser of what we're kind of doing with this project. It's funded by a one-year pilot from the Center for Nursing Research in the School of Nursing. So we're really thankful for their support in helping us to get this off the ground. All right, and we do have some prompts for our panelists, but feel free to answer your questions as well. We'd love to hear from the audience. So one question is, I love what Hillary said about histograms versus machine learning, makes it so much easier to communicate. Who specifically are the most important groups in NC to get this kind of information in front of, and how do we do it? Great question.
All right, well, to some extent, we've kind of a project idea we've been kicking around for some time is to get some of the information in front of providers themselves to understand how their prescribing practices just compare to everyone else, but in a way that is useful and intuitive and helpful to the providers. How can you get that information to providers in a way that isn't, you know, a letter that they have to open or like an extra thing they have to click on every day or some amount of time? But there's been some optimistic evidence about just letting people know where they fall. Oh, I'm prescribing more opioids than my peers. I wonder why that is. I wonder what, you know, is there something I could do, or to, you know, to just even investigate further as to whether this is warranted or not in my patient population. So we've been always wondering what's the best way or most helpful way to get information to providers themselves about how their prescribing practices just compare to what's happening in other practices.
Thanks, Hillary. And Nidhi, you've been kind of key in helping us to connect with community partners for this study. I'm building off HarmNot as well. I was just wondering if you could speak a little bit to, your approach to finding community partners and ensuring good community engagement, and kind of given that we're in more of a urban area here in Durham, how do you ensure that those partnerships also reflect rural perspectives?
Yeah, that's a lot of really good questions. So I think a couple of things that kind of come to mind for me is this idea that relationships don't happen immediately, they happen over time. And so a lot of the folks within the Collaboratory and the community partners that we've been working with over the last couple of years are folks that honestly I've been working with for a number of years. And so they knew that there's this opportunity, and I was in a position where I could really listen to sort of what they needed. And with HarmNot was a really unique situation because the Granville Vance Public Health Department actually came to us and said, we have this program, we think it's really innovative. It's a novel approach to this work in a rural community. We're getting lots of questions from other people that want to do something similar, but we don't have the expertise or the time or the resources to write that story, as Teresa was alluding to. And so it was very much initiated by community folks saying, this is a need that we have, and we were there to listen. And at least given the Duke Endowment opportunity, we have the resources in order to sort of respond to that call. And a number of projects have done that. So certain service programs have also come to us and said, we have this really great work that's happening. We hoping that academic community partnership will add some sort of teeth to some of the work that we're doing so other people pay attention. You have decades of evidence saying that this intervention works, but it looks different now. So how can we share that story as well? And so for me, community engagement, community partnerships happen very much over time. It's having those relationships nurtured so that when an opportunity does come and present itself, you're ready to go. You have the trust and the foundation already built. I think it's being responsive, it's listening, it's being timely, it's being someone who they can trust, right? I think a lot of folks have skepticism of working with academic institutions. They risk a lot by working with us, right? I mean, they're potentially handing over a program that they hold very dear to them and saying, can you tell us our story? And so there's a risk that they might get left out of that, or that the narrative might kind of run away from them. And so we really, really key on involving folks from at every stage of the process, so they still feel like they have ownership. The data is very much sort of shared. We're centering lived experience throughout the whole thing. Everything from design and dreaming of the idea all the way through dissemination of whatever the final product might be. And so I think we hold true the principles of harm reduction really closely in this whole like nothing about us without us principle. And I think that it goes with whoever you're working with, whether it's individual patients. So Padma speaking to bringing patients along and hearing their perspective is really, really important, right? Because if we're trying to change systems of care to better serve them, then they are experts in their own lives and know best what they need. And so let's create opportunities where we can listen very intentionally to that. And so community engagement for me, like the whole rural urban thing, it's like Hillary was saying, it's a lot less straightforward than you think, actually. There's, each community is different. North Carolina is so varied, 100 different counties, 85 different health departments, very different resource allocation depending on populations and just like local conditions and whatnot. And so not making assumptions about what a community is or what it might need or how what their story's been, I think is really a great way to sort of build trust. Also is having those, just not coming in with assumptions about it. Like, we don't know, things might be different now, but it's something that you learn over time in collaboration with folks. I hope that spoke to a few of your questions, Brandon.
Yeah, definitely. Thanks. So a question for Dr. Guler is, how do doctors decide whether an opioid is necessary in pain management? Are the alternatives effective in managing pain in all cases, or are there still situations where opioids are the best option?
Brandon, that's a really, really good question. The opioids have and will continue to play a role in pain management. One particular area where they are particularly useful is in postoperative pain, for instance, which can be quite intense, and being able to address that, with these medications can be very helpful. There are also situations where some patients may benefit from more long-term use of these medications. The decision tree on, when to go, where to go, how to go, is really based on ensuring, we'll go back to the real basics, which is the World Health Organization a long time ago gave us a stepladder approach, which was first line, try adjuvant analgesics, try non-pharmacological strategies, and then in addition, move to the next step. If there's still pain, to add more advanced interventions, things along those lines, including opioids, which really should be reserved for moderate to severe pain and really for severe pain. But should you choose to start opioids, have a plan. What is this? What are you trying to treat? What exactly are you trying to treat? Because one of the flags you'll see is that unlike other medications, where if you have a little bit of a side effect or something, patients are very keen to take, say, we don't want to continue with this medication. Opioids are are one class of medications where they'll tell you that it hasn't had enough effect, but they don't want to come down. They don't want to come off, or that they're afraid of coming off of the medication. And there's a good scientific basis for why they feel the way they do. So the monitoring is really important. Recognizing what we're treating, having some endpoints, setting expectations, and shared decision making. Making sure that the patient is fully consented for what you're about to start, understands both the short-term and long-term risks of using opioid therapy. Because while we're very good about informing patients and consenting them for the risks of, say, procedures and adverse events, we rarely have sat down with them to say, by the way, if we continue these opioids for any duration of time, it can affect your hormonal levels. It can affect your wound healing. It can, make you prone for more infections. Even today, the majority of patients who are on these medications and have been on it for years are unaware of these, potential risks. And so ensuring that we're educating our patients, involving them in the decision-making so they have they can truly balance what is needed and what isn't. So they'll use the lowest effective dose, shared decision-making with their family support, because family and their support structure can many times alert providers to early warning signs that the patient is potentially dependent or, not safely using the medications that have been prescribed. So ensuring that this is, done in a thorough way, I think is extremely important. As far as whether alternative therapies are useful, absolutely, they are. They just are. I mean, a statistic that is well understood in the world at this time is that we in the United States use 80 to 90% of the world's opioids, and we, fortunately, do not have that disproportionate a level of pain in our country compared to everywhere else in the world. And so obviously there are other strategies that can be used to manage pain, and we should be focusing on that as well. Our access to non-pharmacological strategies and to non-opioid strategies is sometimes has been limited just with the reimbursement strategy. So some of the policy work that Margolis and Duke Opioid Collaboratory, all of these, the efforts that are there to help improve access to non-opioid pain management strategies is equally important to addressing this, epidemic that we're facing. So I'll stop there.
Great, thanks. Our next question is for Teresa. You mentioned kind of one of the concerns about mental health treatment was the inconsistency and like it's not kind of consistently available. But I was wondering if you could speak a little more to kind of the current landscape of mental health support, and if you have these data, how that's changed with kind of a shift to more remote telehealth provided services, and kind of what areas we can go to provide good mental health support in combination with medication for opioid use disorder.
Sure. So what we're hearing in our interviews is that, at some times during the program evolution, there was a mental health provider, other times there were not. And that was challenging because as folks kind of spread the workload across the clinics, certain individuals kind of became responsible for certain things about patients. And mental health providers were taking part of that load. And when that person is not there anymore, the load kind of spreads out more. And of course, for any kind of program that's rolling out, there's limited resources. I think there is certainly an impact to the patient as they're working through so many challenges with how their lives are changing as they are working through the program. We see a lot of impacts where folks are going to be more integrated in their communities and more integrated with other people in their family and working through those relationships which had kind of dropped off with their opioid use and kind of transitioning back in. And I think the mental health component of that is extremely important. There have been some challenges with connecting with mental health providers that are not associated with the program. Some providers were not interested in seeing folks from the program. And I think part of that is an educational piece that needs to be worked out with the rest of the community. What other kind of takeaways do we have on this? I think one of the biggest thing that I think about when I think about mental health services within the Granville Vance program is consistency. They're just starting to get somebody back in to help with this. And I think that we'll see a big change in terms of support. And with telehealth, I suspect that it would be useful to allow or to kind of bring in mental health providers that may not actually be living in the area. That's another one of the challenges. In a rural area, there's fewer mental health providers and behavioral health providers. And if telehealth can open up opportunities for patients in the program to be able to connect with other individuals who may not live in the area, but they could still obtain mental health services and behavioral health services, that would be a useful next step.
Yeah, I agree. I think that that kind of hub and spoke model has so much potential, and that's part of why, you know, with this pilot study, we're focused on reaching out to some of these rural counties and seeing if we can help them to build up those. So thanks for that. All right, with our last few minutes, Hillary, I was wondering if you could kind of, so there's a question that might be, which is what kind of specialties in medicine might be more prone to overprescribing? You already mentioned kind of the dental profession, but I was wondering if there are other patterns you've seen. And then beyond that, just kind of what you see as kind of future directions to increase connection between public policy and practice, clinical practice around this topic. Big question with our last couple minutes.
Definitely, and I will say, so I can't speak to overuse so much. I can speak to exactly what we looked at, which was what specialties generate the most new prescriptions for patients who had not been on an opioid in the past year in Medicaid. And those were emergency medicine, OBGYN, and dentists. But of course, Dr. Galora was just talking about how opioids can be important for post-operative pain and kind of really urgent, emergent pain, which those specialties would have reason to be treating. But those will be where, if you want to focus on people who have never had an opioid prescription before, who are the professions that could impact those people the most and really give them the best kind of experience or best education leading up, you know, to this first opioid prescription. Those would be the specialties where I'd focus, at least for Medicaid patients. And I will say that doesn't include other professionals. So it doesn't include physician assistants and nurse practitioners, because we don't have a good specialty data on, you know, what kind of special office settings where they work. So we can split them as easily into categories. And so that would be another place for further investigation. As far as connecting policy and clinical practice, I think I'll go back to what I said before, which is, and I think what all the panelists have mentioned, which is just understanding the context for any changes that need to be made or that are being proposed. I think that there's a real desire to make kind of a big sweeping change that will make a big fix all at once, or big improvement in some area. And I think making the context, you know, doing this detailed work on the context of patient experiences and provider experiences that is done in a rigorous way that isn't just, you know, a few people telling a story and you don't know how representative that is of that particular area or community. This is the kind of work that needs to be done carefully and synthesized in easy to understand ways and made easy to access. So when, the things that we could anticipate would be, being proposed, things about, removing the waiver for prescribing medications for opioid use disorder. That's understanding how much benefit that could have, or if there's other things that need to be done along with that effort to make it successful, is really important. And so understanding what the barriers are to providing effective, treatment for opioid use disorder, I think that is the gap that we experienced, or that we could see happening, is that people would tell stories about why they think prescribers aren't prescribing more opioids or treatment for opioid use disorder. But we don't know if that's really true. We need to talk to them and find out what their barriers are. And is it because the waiver is a hassle, or is it other things that they need? And so if there's a limited set of resources for making changes that will help, you don't want to spend them all on kind of waiver abolishment, efforts, if there's really other things that could help more. I think it's always being conscious of limited resources and time and energy, and not being able to achieve everything you want, but what's the most important thing right now.
Great, thank you. That's a good note to end on, I think. And before we wrap up, I want to mention the next Think Global panel, which is on March 31st, and that's going to be examining treatment for epilepsy in low and middle income countries. So sounds like a fantastic panel. And please join me in thanking our panelists today for talking with us. Really enjoyed speaking with everybody as always, and thank you everybody for joining.